We are going to move right on into the oral abstract presentations. Okay, if I could have the four presenters go ahead and move to the stage. Allison Close, Allison Hines, Jiang Zhang, and Angela Fott. So Dr. Scott Lundy is going to present on behalf of Dr. Allison Himes, microsurgical testicular sperm extraction in a patient with Klinefelter syndrome, and the senior author is Dr. Sarah Veej.
Hi everybody, my name is Scott Lundy. Today I'll be presenting on behalf of our group in Cleveland on our work with microtesting, and in particular a case report of a gentleman with Klinefelter's and B-cell ALL. So as most of you know, Klinefelter's is a common condition that's most predominantly represented by the presence of more than one X chromosome, typically 2, along with a Y chromosome. It's present in about 1 in 600 in the male population, and it's enriched in the infertile population, with about 3% of those men presenting for infertility showing Klinefelter's. In our azoospermic population, it's over 10%. So diagnosis for Klinefelter's has changed in the past decade, but the take-home point here is that the majority of these men are undiagnosed in early age. About a quarter are present to fertility clinics and are diagnosed at that time, but many go their entire lives without being diagnosed. So the challenge for fertility with men with Klinefelter is this loss of normal testicular architecture and function. So on the left here, you can see a normal testis developing from fetal through childhood, puberty, and adult stages. And on the right, you can see the same with a Klinefelter testis. And this is defined by a loss of germ cells, particularly in the pubital area time point, and a hyalinization or fibrosis of the seminiferous tubules, and an overgrowth of the interstitial space. And ultimately, this results in men with prepubertal testis volumes despite being postpubertal, and in the vast majority of men, azoospermia. So the treatment of choice for men with non-obstructive azoospermia, such as men with Klinefelter's, is an operation called microdissection testicular sperm extraction, which many of you are probably familiar with. We call this microtesty. This is an operation that's designed to surgically remove sperm from the testis, and we do this by bivalving the testis and then searching through with a microscope to try and identify heterogeneous areas where spermatogenesis may be present. And this typically appears under the microscope as a plump tubule relative to the hyalinized tubules that surround it. Overall, if you take all the patients who undergo this operation, there's about a 50% sperm retrieval rate that varies depending upon the etiology of their infertility. And it's important to note that when we do this operation, we have to counsel the patients that ICSI is required, because this is never enough sperm to perform a natural conception or an IUI. This is always ART situation. We perform this as either a fresh operation or a frozen operation. Fresh to us means in conjunction with a female cycle and an egg retrieval, so that we don't have to freeze the sperm. This is typically done if the counts are expected to be extremely low or if the patient has failed a frozen previously. And we tend to favor the fresh at our institution for many patients because while it is technically and logistically more challenging, the outcomes may be better. So lots of people have tried to determine what are predictors of success for this operation. This is a partial table showing the work to date. The studies, the blocks in green demonstrate studies that have shown a predictive effect. The ones in gray have shown no effect, and as you can see, there's very little in that all of these studies agree on. There's very little that's been robustly shown and replicated. The only thing is pathology, which of course you can't know beforehand. So this is still an area of ongoing research. We do have a study that we're in the process of completing at our institution to try and identify other predictive factors not previously combined. We developed a nomogram to look at these patients with non-obstructive azoospermia, and using volume, semen, and semen pH and FSH, we were able to predict with some modest ability of success the predicted sperm retrieval rate for these patients. And if it's something you're interested in, there's a link at the bottom of this slide that you can try for your own patients to see if this model holds. And we are currently in the process of trying to validate this. So what about microtesting in the Klinefelter population in specific? So this is a nice meta-analysis published a few years ago that looked at all patients that have been published in the literature who have undergone microtesty and ICSI for men with Klinefelters. And the take-home messages are that microtesty sperm retrieval rates vary widely, but are thought to be approaching the 50% mark. So this study found 45%. And of those men who had a sperm retrieval that was successful, about 40% had a live birth rate per ICSI cycle. So if you combine these two numbers together, the overall live birth rate for all patients presenting to clinic with Klinefelters is about 16%. So it's not as high as we'd like it to be, and I think it's important to recognize that that number is still reasonably low and counsel the patients appropriately. So oncotesty is a type of microtesty that's performed particularly in the oncologic setting. This can take a lot of different forms, and to date there have only been about 20 published reports in the urologic and global literature for oncotesty in the strict sense of the word. This is typically done in the setting of testicular cancer or primary germ cell tumor, although not always, can be done for hematologic malignancies as well, as you'll see. And the overall success rate is about 50%, but that varies widely depending upon the malignancy and whether chemotherapy or radiation were administered or what treatments the patient received. So when you look at this literature, I think it's important to recognize that this is a very heterogeneous population, and we have to recognize whether this is a primary testis cancer mass and whether the oncotesty is performed at the time of orchiectomy synchronously. And that can either be done on the ipsilateral testis that we take out and place on the back table and dissect, or it can be done on the contralateral testis in vivo. This can also be done at a later time to the orchiectomy and done after the patient recovers from their initial surgery at the risk of potentially that patient then undergoing gonadotoxic therapy in the meantime. And then for other malignancies, this is also highly dependent upon what treatment they've received and the timing of that treatment. So the case I wanted to discuss today quickly was a gentleman who was a 21-year-old gentleman who was diagnosed with Philadelphia-like B-cell ALL. He was diagnosed at age 20, and in the course of his workup, he was found to have Klinefelters. At that time, he underwent sperm banking, and unfortunately, several specimens at the time were azospermic. So he then subsequently was treated on trial on AA-LL1131 induction, followed by consolidation on AA-LL1521, which did include gonadotoxic treatment and cytoxin treatment. Following this treatment, he had a pretty rough course. His course was complicated by aspergillosis, colitis, adrenal insufficiency. He developed anaphylaxis as part of his chemotherapy regimen and was arrested and had to be admitted, but did fortunately make a full recovery. And then he had a minimal residual disease that was present, and so the plan was to bridge him with blinatumomab and then start planning for a bone marrow transplant. So in the process of all this, he presented to our urology clinic for fertility preservation prior to his bone marrow transplant. You can see here his hormonal parameters. As with many men in Klinefelters, the testosterone is, in many men is low, but in this gentleman it's actually normal. I'd say the average patient we see has a low normal testosterone, so they're not all zero or extremely low. And you can see here the FSH and LH are significantly high, consistent with testicular failure. So we started him on an anastrozole to precondition him, and then he underwent a microtesty. This is a bilateral microtesty, which is our standard protocol in these cases. And we also perform a polar biopsy in addition to our full microtesty format. The pathology from this, as expected, showed hyalinized tubules with some Sertoli cell-only tubules. And the path report did not find any significant spermatogenesis, nor did it find any neoplasms. But the andrology report did, in fact, identify non-motile sperm in, surprisingly, 7 out of 7 specimens, with the highest concentration being 1 sperm in 5 microliters. So this was frozen, no thaw was performed, given that the numbers were quite low. And the patient subsequently underwent allogeneic bone marrow transplant. He did develop graft versus host disease, but recovered from this, and he's doing well now and finishing college. So in conclusion, microtesty represents the best chance for us at its current state to preserve fertility in patients with non-obstructive azoospermia who are postpubertal. I think it's important to set realistic expectations for these patients, particularly counsel them on the importance of understanding that sperm retrieval success is different than live birth success, and those two are additive. And then I think we should move towards standardizing some of the oncotesting nomenclature to allow for a more streamlined understanding of the literature that's been reported. And then finally, for this patient in particular, one of the things we struggle with is non-modal sperm for ICSI, and I'm hopeful and optimistic that there will be advances in this area in the coming years. So thank you very much for the time, and thank you for allowing me to be here, and I'm happy to take any questions.
Thank you, Dr. Lundy. We'll take 1 or 2 questions. Dr. Nahata?
Yeah, so that was great. I was just curious, in your nomogram, are you looking at pretreatment with testosterone? Because I know that's one of the biggest clinical...
I'm sorry, testosterone?
Yeah.
Yeah, we tried a number of different factors. We have a series of approaching 200 microtestes that we've performed in sort of the modern era at our institution. And we did look at univariate analysis for a number of these factors, and testosterone was not predictive. Neither was LH, nor were ratios of those.
Okay, great.
Dr. Orwick?
So I apologize that I stepped out in the beginning, but I noticed at the end that you said due to the low sperm counts, you didn't cryopreserve, and I wonder what the threshold would be to preserve versus not. Yeah,
we did cryopreserve the non-modal sperm. We didn't perform a post-thaw because we were worried about loss of specimens. So there is sample frozen for this gentleman.
And these are testicular sperm, so when you say non-modal, you mean non-twitching?
Yes, correct. So we try and separate that out. As you know, and many know, the percentage of motility in the testis is low, although not zero.
Thanks.
Can I just ask a quick clarifying question? Did you mean testosterone level? I was asking about testosterone treatment.
Oh, testosterone treatment, it's a good question for the Klinefelter population, particularly because as most of you know, testosterone treatment essentially blocks all spermatogenesis. And so in the Klinefelter's patients who do need testosterone, that's a difficult situation, and that really does influence our timing of intervention. We have moved away from performing sperm retrievals in young men except when they're on testosterone. So the nomogram that we presented was actually for all patients with NOA, not just Klinefelter's patients, and in that situation, men on testosterone were excluded.
Final question.
Hi, Rod Mitchell, Edinburgh, Scotland. So I just wanted to ask about the Klinefelter patients. So when you do a TZ, do you have an optimal age at which you would do the TZ?
Yeah.
And the reason for asking is that we're often getting younger and younger patients with Klinefelters asking for TZ, sometimes teenage patients,
Sure.
because they're concerned that they're going to lose spermatogonia ongoing, which not sure the evidence is so strong. So do you have an optimal age? And secondly, do you use anything to try and stimulate before you do the TZ to maximize your chances of getting sperm?
Yes, we typically use an astrazole, depending on the patient's hormonal parameters, to answer that question first. And then as far as the age, it's really controversial. I think years ago, people were intervening earlier, and now I think the push has been more towards intervening later. The data supports that the max efficacy of a microtesting for these patients is probably in the early to mid-20s, as opposed to as teenagers. And I think that we feel that undergoing a surgery for a patient who's not yet even considering children and then will have to live with the emotional consequences of a negative outcome for the rest of his life is potentially damaging. And so for those reasons, we tend to wait until they're at a state where they're considering paternity and where we can potentially save them 10 years of emotional worry that may not necessarily be required.
Great, thank you.
I do have one question.
Sure.
Did you perform the microtesting in that patient after chemotherapy?
Yes.
And
Yes, so we tried before, and the patient was azospermic, and so this was after Cytoxan treatment, before bone marrow transplant. So this patient had a lot of things working against him.
Okay.
Yeah.
Thank you so much.
Thank you.
Okay, we are ready for Dr. Allison Close.
So thank you so much for letting me be here today. I'm going to present our research on gonatotoxic risk stratification in leukemia and lymphoma frontline phase 3 children oncology group protocols from 2000 to 2021. I could not do this work without my amazing collaborators, many of whom are in this room, and I just want to thank you from the bottom of my heart.
Can you advance the first slide for her?
All right, so the Pediatric Initiative Network recently published recommendations for stratification of treatment-related risk of gonadal dysfunction and future infertility based on sex, pubertal status, and exposure. The goal of this was to standardize risk discussions and find common definitions for both researchers and clinicians alike. Oh, if I'm good, okay. So to just orient you a little bit to the risk stratification system, and this is not what I'm going to be talking about in this study significantly, but I do think it's important to understand. So on the left, we have the female risk chart, and on the right, we have the male risk chart. And we do see that the categories are in yellow, minimally increased risk, in orange, significantly increased risk, and in red, high level of increased risk. And these categories were determined by a group of 27 individuals from 15 institutions, many of whom are in this room, all who are a multidisciplinary group with fertility expertise. And given the lack of adequate studies with self-reported infertility, the percentage chance of infertility could not be assessed, and thus this is why they use terms that are describing more risk-based. Then going down, we see that they looked at alkylator agents based on CED, or cyclophosphamide equivalent dosing, and for girls this was divided into pubertal and prepubertal. Male risk status does not vary based on pubertal status as significantly, and so males were just a single category. And they also looked at heavy metal exposure, the need for transplant, and radiation exposure. And I would encourage all of you, if you have any questions about this risk stratification, to review the study from Meacham et al. At JAYAO, and the reference is below. These recommendations are not integrated into upfront Children's Oncology Group protocols, and these protocols, so the Children's Oncology Group, for those who aren't as familiar, is an international group that creates trials for children and adolescents with cancer, and approximately 90% of children and adolescents in the United States are treated at Children's Oncology Group centers. So this makes up a large portion of our patient population. So the purpose of this study was to provide a comprehensive guide in gonatotoxic risk categorization for pediatric, adolescent, and young adult patients with newly diagnosed leukemia and lymphoma treated on current era COG protocols. And we hope that this could be used in risk counseling at diagnosis and to aid in fertility risk discussions in AYA survivorship. We identified upfront leukemia and lymphoma phase 3 treatment protocols from 2000 to 2021 using the COG website with approval from COG leadership. We evaluated protocols for gonatotoxic therapies and assigned risk levels based on the PIN risk stratification system that I discussed previously. The COG long-term follow-up guidelines were used to identify gonatotoxic agents. Agents not on this list were categorized as unlikely to cause risk, and alkylators were converted to cyclophosphamide equivalent dosing. Dacarbazine, an alkylator agent, does not have a conversion factor and was noted to have unknown risk. Dose calculations and risk stratifications were verified by 2 independent reviewers. So this is our first table looking at the risk of future infertility and gonatotoxic dysfunction and gonadal dysfunction for COG phase 3 treatment protocols for newly diagnosed acute lymphoblastic leukemia. And just in total, we did look at 26 protocols with 97 treatment arms. And specifically for ALL studies, we looked at 11 protocols with 52 treatment arms. And to orient you a little bit to the table, we do have the protocol in gray. So for example, AALL 1731, and then we have the treatment arms below. We did collapse the treatment arms when they had equivalent CED dosing and risk level, just because or else it would have been a very cumbersome table to look at. So I did want to highlight that for the alkylator agents, we calculated the CED, and for acute lymphoblastic leukemia, the CED ranged from 0 to 13.2. And I also think that it's important to note that almost all of the high-risk patients were really male patients in this group, and that although not identified on this table, in the publication it will be, but if patients needed testicular radiation or had refractory disease and needed to come off study to go to transplant, they would also be considered high risk. So here is the AML study. We reviewed 7 protocols with 18 treatment arms in total. Again, the table is oriented the same. Of note, most upfront AML studies have no alkylator agent, so that's why they are designated unlikely to be at risk. However, transplant is built into the AML studies for high-risk patients. So basically it was either unlikely to be at risk or high for our AML patients. The risk, now we looked at the non-Hodgkin's lymphoma, and there were 3 protocols with 11 arms. Of note, we did include the acute lymphoblastic lymphoma studies in the ALL table based on the COG kind of classifications. So also, I just think that this is helpful to note that again, only real high-risk categories are the males. And then finally, this is the Hodgkin lymphoma table. We reviewed 5 protocols with 16 arms. And we have a few protocols here where pubertal female patients would also be considered high risk, as indicated here and here. And of note, actually, many Hodgkin lymphoma protocols do require radiation between the doses of 21 to 36 gray for most patients. And if that would include the pelvis or ovaries, then they would also be considered high risk. And patients would receive radiation. It's protocol dependent, but often if they have residual disease or they have inadequate response to therapy. And also of note, the S1826, the newest study, the only alkylator agent in there is dacarbazine, which is why we noted that is unknown, but it is unlikely to cause significant risk. So this is more of a visual representation of the distribution of risk level for treatment-related gonadal failure and infertility and COG treatment protocols. And I think the important things to note here are, so gray being that there's the unknown category, again, that would be our dacarbazine group. The green is unlikely to be at risk, yellow minimal, orange significant, and red is high. And overall, 26% of the leukemia and lymphoma protocol arms place patients at a high level of risk in at least one patient group. Again, mostly being the males as noted on this graph. And this is just a different way to look at it, showing the percentage of protocols. So before we looked at protocols and treatment arms, this is just protocol specific per disease type with at least one high-risk group. And again, so blue being the prepubertal females, orange being pubertal females, and gray being males, noting that the highest risk group is, again, males. So in conclusion, most modern upfront COG protocols for leukemia and lymphoma do not have a high risk of gonatotoxicity for women and girls, with more protocols putting men in the high risk category. The use of this system allows for quick identification of patient risk level for fertility consults and interventions during initial diagnoses, and during survivorship, the level of risk can also guide counseling and surveillance. And future directions, we are actually in the process of doing this for brain tumor and solid tumor protocols. And I'd like to acknowledge that this research report in this abstract was supported by the Children's Oncology Group and the National Cancer Institute of the National Institutes of Health. So thank you very much.
That is amazing work. That's a lot of hard work, and it's great. Questions, please.
First of all, thank you. This is such a help, and I'm so glad to see the future directions that incorporate some of the other cancer diagnoses. Are there any plans to incorporate the risk stratification directly into the protocols for easy access to information, particularly for the providers not in this room who don't necessarily have fertility at the front of their mind?
Yeah, so that is a great question, and I think that we would all love if that were to happen. So this is really the most recent studies. We looked at including studies when there's two different groups, CCG and POG, when they came together in 2000. So these are really current studies. But again, these tables will soon become irrelevant or as new protocols continue. And so our goal after publishing these would be to talk to the Children's Oncology Group for future studies to have this risk classification really built into the initial study protocols.
Thank you.
Hi, Doug Fair from the University of Utah. Great work. As somebody who does survivorship and pours through all of these protocols to figure out all the risks, I appreciate how much work you've put in, so that's really great. I think just to echo the comment, the next step might be putting them in protocols, going to the NCCN for the AYAs, and I sit in the AYA committee. I don't sit in any of the subgroups there, but again, I think putting it in the protocol, as we know, we follow that like gospel, and so if it's listed in the protocol, and then if you can get the adults, the AYAs on those different subgroups, the bone sarcoma, the leukemia, I think that might be another great place to continue this great work.
Thank you very much, yes.
Thank you very much. So very nice work in developing these protocols. I think it's really important to have these cutoffs. I'm going to challenge you just slightly on the male side with the cutoffs, and just give you a hypothetical scenario. So you have at the moment less than 4 cyclophosphamide equivalent dose is minimal, and anything more than 4 is high risk. So you go straight from minimal to high risk. So when you're counseling a patient who's getting 3.9, and you're counseling them to tell them that they're at minimal risk, and then you're counseling another patient in the room next door who's getting 4.1, and you're telling them they're high risk, how do you approach that scenario? And is it simply a case of going from low to high, or is there a middle ground in there somewhere?
So great question, and I was involved in some of these meetings, but not all of them. And I know that this was a very debated topic, but ultimately, for the testicular tissue cryopreservation protocols, really the cutoff was 4. And so I think it was felt that which should be considered high risk based on Dan Green's work. But you're exactly right. It's obviously a continuum, and it is really hard to counsel patients getting 4.1 versus 3.9. But I think we all just have to do our best, and that's why one of the reasons they didn't use percentages too, because it's hard to really give an exact percentage. But my personal take is that, and someone can challenge me on this, but that really all post-pubertal males who are able to sperm bank should do that. And so really, if you're getting 3.9 or 4.1, our counseling should be the same. And really then it's more in survivorship where we would then discuss, semen analysis in the future and to see what their actual, level of dysfunction would be.
Yeah, so I think the bigger challenge is perhaps the prepubertal patients in terms of thinking about whether to offer testicular tissue cryopreservation.
Correct.
And I guess the other point is that Ellen's talk very nicely showed that we need the follow-up data on these patients to be sure that what we're calling high risk is truly high risk and so on. And we might find that we're not right, and we need to keep modifying these protocols as the evidence comes in.
Exactly, and I think that this is based on our current best data, but these protocols I know will change in my lifetime as we get more and more granular data about this. And I think that that is the beauty of being able of having something, but knowing that we are imperfect beings and that things will change, and that as a group that we are all accepting of those changes and willing to make dose or change our recommendations based on new data.
Brilliant, thank you.
One last question, please.
Hi, I'm Barb Lockhart from Lurie Children's in Chicago. Just 2 comments on COG and our continuing evolution. There are supportive care guidelines that state in the COG, on the COG website, give recommendations, not really recommendations, but they do deal with fertility preservation. They're hard to find, and I think if you would quiz the majority of COG members, they would not know that they're there. So we need to do better. I'm also the nurse for the Bone Tumor Committee, and we are being more conscientious about how we recommend or where do we put in fertility preservation. A lot of the solid tumor protocols, the newer ones, do say fertility discussion as part of your pre-treatment, but they don't give a whole lot of guidelines.
Correct.
Or the more important piece is they don't really identify what the patient's risk is. So there's some information there, but we need to do better.
Yeah, I totally agree. Thank you for that.
Thank you. This is very exciting. And as the chair of the Female Oncofertility Scientific Committee, I volunteer our committee to help with the young adult population in moving this forward.
Great.
So
Well,
great
thank
work.
you. Thank you, everyone.
Okay, our next speaker is Dr. Angela Fott, and the title of her presentation is Implementing a National Fertility Preservation and Reproductive Late Effects Database to Improve Outcomes.
All right, so as Leslie mentioned, my name is Angela Fott, and it's an honor to be speaking for you today. I want to thank the organizers of this wonderful conference and all of you for attending and your time for listening to me today. I'm going to be talking about the National Oncofertility Database. It was initiated by the Oncofertility Consortium and is being led by Dr. Leslie Appiah at the University of Colorado. Yay, Leslie. All right. Green button. Okay, let's start out with some background. So, as you all know, the 5-year survival rates for children and young adults with cancer are approximately 85%. Infertility and adverse health affects these survivors. In addition, non-malignant conditions can also threaten fertility. Since there's a lack of a big population-based study, this national database was created. We're hoping that this national database will promote data sharing, facilitate multi-center research, and improve outcomes. So it was kind of a beast to get going, and we had a very large multidisciplinary team that worked together. We had a lot of different types of physicians, gynecologists, REIs, oncologists, plus our nurses, biostatisticians, informaticists, and the list goes on. We first are implementing the database at the University of Colorado Hospital, and we've already gotten a sample of that data, which I'll show you in a minute. And then next, we are going to, or very shortly, we're hoping, we're going to have data from Children's Hospital of Colorado. So the data that I mentioned that we have from UCH is historic data starting at the time of when our EPIC system was created, so starting in 2011 and going up to 2009. That's our historic data. And then going forward, once Leslie arrived at Colorado from 2019 and on, that's our prospective data of when we actually had our program created. And that prospective data will have 2 groups in it. One is those patients that were seen by a fertility specialist on our team, and then those who meet the age criteria and were treated by cancer therapies or cancer-type therapies. So as I mentioned, the eligibility criteria is patients receiving cancer-type therapies, and the ages are from 1 month to 40 years. We collect a lot of variables, and just to give you an idea of some of them, we collect demographics and cancer diagnosis and treatment information, fertility preservation therapies, and reproductive health outcomes. Currently, we are developing data management and then reporting processes, and we're going to apply that to UCH, or we actually are already. And then we're going to apply it after that to children's, and we'll automate the process so that it can be applied to each new site that we add. So we're going a little bit backwards with this slide. We're going to start on the right-hand side, which gives you a more in-depth, I'm not used to these microphones, sorry. It gives you a more in-depth list of the section headers in our data dictionary. So you can see, looking at that list, what types of categories we have included in the database. And then on the left side, we actually have a snapshot of our fertility preservation flow sheet, and this is a portion of the female flow sheet. So we have existing variables like demographics and cancer information that already are in EPIC, and then there's a portion of the data that we wanted to add, and we put it into our fertility preservation flow sheet, and the care providers fill that out when they're doing a consult. Okay, so I'm a biostatistician. Let's look at some data, right? This is my favorite part. Our first sample, again, this is the adult hospital. We have 6,313 patients, and the breakdown of that initially is almost all of those are cancer patients at this point, and then we have 381 non-malignant hematologic diagnosis patients. We have another section of data that are other non-malignant patients that we're going through and cleaning. We need to categorize those, so we will add those in the future. When you move to the top right corner of this slide, you can see the race and ethnicity distribution. And this is pretty common for Colorado to see that most of the people are white, non-Hispanic. And then when you move to the bottom left pie chart, we're looking at the overall age distribution, and you can see that the majority of the patients are 18 to 39, and that again is because we just have the adult hospital data for you today. As you move then to the right pie chart on the bottom corner, you can see that the majority of the patients in this population are 61% female. Okay, so I wanted to give you an idea of the type of diagnoses that we have so far. So this list between the two lines are all cancer diagnoses, and you can see there's a breadth of different diagnoses in this data set. And then below the line at the bottom, there's the non-hematologic or non-malignant hematologic diagnosis with 381 patients there. And the thing I wanted to highlight is that breast, central nervous system, and lymphoma were the most common cancers in this population so far. So now thinking about a little bit broader of the more common diagnoses, we're going to look at the diagnoses and the distribution of age for each diagnosis. So starting on the left-hand side with bone cancer, it goes to testicular cancer, and then on the far right we have non-malignant hematologic patients. And you can see for most of them, the majority, again, this is our adult hospital, so the majority of them are 18 to 39, except for, if you notice, renal and urinary cancers. They actually have a little bit different of a distribution, with 40% in that lowest age category at less than 15 years old, and then 60% in the 18 to 39. Oop, pushing the wrong button here. Okay, then continuing looking at demographics for these common diagnoses. Again, we have bone cancer to testicular cancer along the bottom, and then the non-malignant hematologic diagnosis. And this is looking at sex distributions. So bone, breast, CNS, ovarian, obviously, have more females than males. But then as you look at leukemia, lymphoma, sarcoma, testicular, and even the non-malignant hematologic diagnoses, there are more males than females. All right, so here's some reproductive data for women who are 18 years or older. And if you start by looking at the pie chart on the left, you can see that 60% of the women have not yet conceived, and then 40% have conceived at least one time or more. Now, focusing on that green portion, we're going to move over to the pie chart on the right, and that's actually out of those who have conceived at least once, did they have at least one live birth? So it's kind of out of that 40%, so you notice that the sample size gets a little bit smaller from 3,600 to 1,400. And the good news is that 83% of those women had at least one pregnancy. 5% did not, and then 12% had missing data. So for conclusions, we've completed a few set things that I wanted to mention. So we've demonstrated feasibility of automating a data pull from our electronic medical records. We started prospective enrollment. We have detailed cancer and follow-up data. And we're already working on our descriptive analyses for this data and creating those automated cleaning processes and reports. In the future, though, we are focusing next on children's, and we're going to automate the data import from there. And then also, hopefully, from you guys, we'll add external sites in the future, and we were talking about doing that starting January of 2023. So that's exciting. And then we are going to refine quality improvement across centers, which really I think will happen with every center that we add, because potentially we could learn new information with each center that we add. And then we're going to collaborate with the Children's Oncology Group to expand our network. And then, then if you want to request data, an Oncofertility Consortium committee will be created to evaluate data requests, so it actually won't be, even though CU will be heading the data coordination and helping people get data into the database, the consortium itself will have a committee that decides, what data requests will be accepted. So this is our team. I mentioned it was very multidisciplinary, large team, and I'm really excited to be here representing them today. And there is our email address if you would like to contact us with any questions, or if you're interested in participating in this database, please feel free to reach out and I will get back to you as soon as I can. And I just wanted to thank you all again for your time and for listening. Any questions?
Yes.
Hi, Eileen McMahon from Toronto. I just wondered, the data you have of the different diagnoses, was that all cancer diagnoses or just patients seen for oncofertility consults?
So that was all cancer diagnoses, and there was more of a variety of the list. We did try and group them just so that it wasn't an overwhelming table, because it was already pretty long as it is. But yes, it's basically all potential cancer diagnoses that we had at the adult hospital.
And then your data on pregnancy, were those people trying to conceive?
It was just anybody who was 18 or over. So they may or may not have been trying to conceive.
Okay, thanks very much.
Yes, thank you.
Yes, hi.
Hi.
A comment and a question. Actually, she stole my question.
Oh. Well, it was a good question, apparently.
It was, exactly. But a comment too. Number one, in my view, this is exactly the sort of database that needs to be structured. Congratulate you on that. And I think this is something that maybe thinking beyond your particular setting, it needs to include a uniform amongst the Onco group to get a true uniform database nationwide, right? So
That's what we're working for. Thank you so much.
Yeah,
Hi, James.
Hey, Angela. I just wanted to say really great work and exciting to see potential moving towards the national database. I have two questions. One, probably easier to answer than the other. I'll give you the easy one first. You want to have the reproductive late effects tracked in this, and so you shared data on birth rate and all of that. Is there any plan or in the first iteration, is there going to be fertility status measurements such as AMH or semen analysis or things like that, or will that be a later iteration? And then my second question is, as far as the data extraction from the medical record, can you explain how that works, or is
Sure.
it really hard to do, or yeah?
Oh, no, I can explain that. So for your first question, that's actually a very important question. And unfortunately, we didn't have that data cleaned and ready to share, but we are pulling AMH and FSH data already. So that will hopefully be soon to be shared with everyone. And then you were asking about how we got started. Actually, that was a special time with Leslie and I and our EPIC team, where we went through quite a list of diagnoses types, procedure types, ICD-9 and 10 codes, and it took a while, but we eventually got to a list that we agreed upon and that the EPIC team could pull. So that was kind of the first step. And then also we created our data dictionary and the variables that we wanted so that we could work with them to say, okay, using these ICD codes, we want to pull these people, and this is the information that we want to pull. And we had two different types of variables, those variables that are existing in already in EPIC. So for example, demographics, we have beacons, so any cancer information. But then for the things that weren't available in EPIC, we created that fertility preservation flow sheet, and that asked all the additional questions that we wanted to ask. So for example, fertility preservation, specific variables, menstruation, we asked a lot of detailed questions there that we added through the flow sheet.
And can I just add to that, for the late effects, there are questions about complications from graft versus host disease, radiation injuries, so there are a host of late effects that are included. And then also just to clarify on the data pool, as Angela stated, we needed to provide the EPIC team with the ICD-10 diagnoses for all of these factors, and we used some of our data analytics people in the OBGYN department, and then the EPIC team was able then to translate that into SQL code that they could use to capture from the EMR. So when we go to other sites, we will be able to present that initial code for them to use, and they will work with their data analysts or EPIC analysts there to do that at their institution.
So the good news is you don't have to replicate that work. We did it already, and so we can share it with your teams to pull the appropriate data. Thanks, Leslie.
Two quick questions.
My quick question, first of all, congratulations.
Thank
to
you.
get through an EMR like that. But my second question is related to EMR. Some of us work in multiple EMRs. EPIC to me seems more user-friendly, but most of our data is in Cerner. So is there any plans for your team to make this available in other EMR systems?
Yes, so actually, I can't remember where she was, but there were other people that asked that same question. And so basically, to me, data are data. So as a biostatistician, as long as I can take data from your database, whatever type it is, and we can kind of conform the variables into the same format that we have, it's okay if you don't have EPIC. The only thing that I was thinking would maybe be a little bit more difficult is the fact that we have that flow sheet that resides in EPIC, and those are specific questions, and there's a lot of detail in there that we would want to make sure we could get, and those are questions that we have the care providers ask during consults. So as a sidebar, I was kind of thinking for those people who don't have EPIC and we can't put it in there, maybe we can put it into a REDCap database, and we can, give you the variables in the flow sheet so you can still get that information even though you don't have the flow sheet in EPIC. So we can work with you.
All right, last question. We are 10 minutes behind schedule.
Oh my gosh, I'm
I'll,
sorry.
I'll talk fast. Lillian Meacham, Atlanta, that's beautiful. I've always said having an epidemiologist on your team is a superpower. So
you.
that was great. My question is, so much of what we really want to know is longitudinal data. And for many of us who work in a standalone pediatric center, that's very hard to capture, especially when you're talking about infertility.
Yes.
So the question becomes, how can we do that? Getting patient-reported outcomes and being able to incorporate
Sure.
both quality of life, decision satisfaction, and reproductive outcomes longitudinally.
Yeah, that's a great question, and it is very important. And actually, we are already planning on getting longitudinal data. So at our institution, we're going to collect data monthly initially and see how that goes, and then we might move to quarterly. So if somebody comes in at 5 and has cancer, or even reproductive outcomes that we want to look at for an adult, for example, we will get all of the updated information for that person in the first pull, but then as time goes on, we're going to continue to collect data. So any time that somebody comes in, and for that first example, the patient recurred, we'll get that additional information about the recurrence. And then for the adult that maybe down the line wants to start having children or did start having children, we'll get that additional information too. So it'll just keep adding, and as long as it's entered into either EPIC or Cerner, for example, we can get that longitudinal information. Thank you so much, everybody.
Okay. And then we have our final speaker, Jiang Zhang. A 3D in vitro follicle growth system preserves molecular signatures of gonadotropin-dependent follicular genesis.
Thank you, Leslie. Good morning, everyone. My name is Jiang Zhang. I'm a postdoc in Dr. Shuo Xiao's lab from Rutgers University. And I would like to thank the committee for giving me this opportunity to present my research work here, which is about a 3D in vitro follicle growth system preserves molecular signatures of gonadotropin-dependent follicular genesis. And so yesterday, our keynote speaker, Dr. Teresa Woodruff, have given us a comprehensive introduction on ovary biology and follicular genesis. And today, I will just focus on the FSH, or gonadotropin-dependent follicular genesis, as the pre-antral follicle developed into the pre-ovulatory stage. So the alginate hydrogel-based encapsulated in vitro follicle growth system, or EIVFG, can maintain the 3D structure of ovarian follicles and can support the follicle growth. It has been applied in many different species, including mouse, non-human primate, and also human. So just take the mouse follicle as an example. We can see the multilayer secondary follicle can develop into the antral stage during the 8 days culture of EIVFG. And we can induce the ovulation by HCG treatment. The follicle will rupture and release an metaphase 2 oocyte. And the remaining somatic cell will form a corpus luteum-like organoid. And in addition, we can also measure the hormone secretion from the conditioned medium by ELISA. We can see both the estradiol and progesterone showing the ovarian cycle-like hormone profile. And furthermore, those M2 oocytes could be fertilized and developed into the blastocyst stage. If we transfer them into the pseudo-pregnant mice, we can also get the live birth pups. So we have shown that this EIVFG system can phenocopy most of the key ovarian events. Then we want to ask the question, how about at the molecular level? So in our study, we hypothesized that follicles from EIVFG system can preserve the molecular signatures of gonadotropin-dependent follicular genesis. To test our hypothesis, we collect the mouse follicles from EIVFG cultured day 0, day 4, and day 8, and perform the single follicle RNA sequencing analysis. For our RNA sequencing result, first, these PCA plots show our follicle sample were clearly separated into different clusters based on their culture days. And those volcano plots also showed there were various number of differentially expressed genes when we compare between different culture days, which indicating a very dynamic transcriptomic profile. For the ovarian steroidogenesis-related genes, their expression pattern were consistent to previously published results from the in vivo model. For example, the CYP19A1 or aromatase, which is responsible for the synthesis of estradiol, we can see there is a great induction from day 4 to day 8. And in addition, we also see there were great inductions for both FSH receptor and LH receptor, which indicate the full maturation of follicle growth. And for the other follicle maturation-related genes, like PAPPA, NR5A1, and also the inhibin subunit beta A, we can also see they are highly induced. And for the AMH, as Dr. Jingxu mentioned in her talk yesterday, we can see there is a dramatically decrease on day 8, which indicate the follicles grow into the antral stage. And besides these representative genes, we also want to identify the temporal gene expression profile for our RNA-seq result. Therefore, we perform the soft clustering using the short time series expression miner software, which give us those significant gene expression profile 1 to 8. Each of them have a very unique expression pattern. And we further perform the gene ontology and KEGG enrichment analysis on each gene clusters. And due to the time limitation, today I will just show you some KEGG enrichment results. And so for cluster 1 and cluster 3, which have an increasing expression pattern, we can find many signaling pathways that are related to metabolic activities, and also we can find the biosynthesis of steroid and as well as the amino acid, which makes sense because we expect as the follicle grow, they will secrete more and more estrogen and also build up their biomass. And on the other hand, for cluster 5, which has a decreasing expression pattern, we found DNA replication and cell cycle were enriched, suggesting the downregulation of cell cycle at the late stage of follicle growth as they are approaching the maturation stage. So I have to say this is a very huge data set, and we are still doing more deeper analysis on it. And we hope to identify some novel genes or signal pathways that are critical for the gonadotropin-dependent follicular genesis. So to summarize, the take-home message is we have demonstrated that this EIVFG system can preserve the molecular signatures of gonadotropin-dependent follicular genesis. And currently, in our lab, we are using this model to study ovary biology and ovarian disease, such as PCOS, while also using this model to study the reproductive toxicology, including the endocrine disrupting chemicals, as well as some chemotherapy drugs. And furthermore, this model could also provide us a potential option for the female fertility preservation with the combination of vitrification technique. So with that, I would like to thank my advisor, Dr. Shuo Xiao, and all the other lab members. And I would also like to thank all our collaborators and all the funding support. And thank you for your attention, and I will be happy to take any questions.
Are there any questions from some really smart people in this audience? Yes.
Sorry, I'm also too short for this mic. So really incredible work. I know as somebody who's also trying to do some follicle culture, this is non-trivial at all. For the single-cell RNA-seq, my understanding is that the majority of the platforms do not allow you to analyze the oocytes because they are larger than what the sequencing library can be prepared for. So in your analysis, are you keeping the oocytes and doing a separate analysis with them later, or what's your plan with that?
Oh, thank you for the question. Sorry, so I should clarify more clearly. We are doing the single follicle RNA sequencing, but not the single cell RNA sequencing. But we are also in the way to explore a better way how to do the dissociation and then how to separate the granulosa cell or somatic cell from the oocyte, and then that may facilitate us for the next step to do the single cell sequencing for our follicle samples. Yeah, thank you.
And as a follow-up question, when you are isolating your follicles, what stage follicles are you initially isolating for your culture? And have you found any differences if you started out with transitional or early primary, early secondary stage compared to some of the later stage secondaries?
So in this study, we start to isolate the follicle from the multi-layer secondary stage, so they are already pre-enteral follicle. Actually, for the earlier stage, early secondary or even primary follicles, it's still hard for us to culture them in vitro. And so we are still optimizing our protocols, and we are definitely want to look at what happened in the non-FS dependent follicular genesis time.
Great, thanks very much.
Yeah, thank you.
And one last question.
Thank you for very nice talk. So my question is, do you see any kind of heterogeneity when you do the kind of single follicular transcriptome?
I'm sorry?
The difference between the individual single follicles. Can you see the heterogeneity of the gene expression?
Do you mind to just pull your mask down just for one moment while you ask?
So
Thank you.
my question is, do you see the heterogeneity of the gene expression in each single follicles when you do the single?
Heterogeneity of.
Oh, yes. So for the in vitro cultured follicle, actually, they are more there's not too much heterogeneity, so they are more to be clustered together, and they look very similar, I mean, for our in vitro model. Yeah, but maybe there are some heterogeneity in the in vivo developed follicle, which may give up more information, but we need to look at more data.
Okay. Thank you very much.
All right, well, please help me in congratulating our abstract winners on these amazing oral presentations.